we'll go to the last session on intervention as a permanent solution. So in this context, I would like to call upon Dr. J.P. Sahani. He was there in the morning. And Dr. T. Sundar from Apollo Hospital, Madras, Chennai. Dr. Viveka Kumar, Max Hospital, Delhi. Dr. Santesh Kaushik, Apollo Hospital, Navi Mumbai. So over to the chairpersons to start the session. Over to the chairpersons. Dr. Sahani is there. He was there. Dr. Viveka Kumar. Okay. Dr. Viveka Kumar and Dr. Santesh Kaushik can start the session. I think Dr. Khanna will join a little later. You can start with Dr. Ulhas Pandurangi, I think. You can introduce Dr. Ulhas Pandurangi. Over to the chairperson, Dr. Kaushik and Dr. Viveka Kumar. Dr. Khanna is busy in a procedure. He will join later.
So we'll
that is why Dr. Ulhas
Pandurangi.
He is also in the procedure. So Dr. Ulhas can start.
So hello everyone. It's my privilege to participate in this WCC-ICC Heart Failure Summit. I'm thankful to Dr. Mahapatra and Dr. Manoria for this opportunity. And I hope I do justice to the august audience who have logged in, sacrificing their Sunday siesta. I sometimes feel webinar pandemic is seeming to be more hard-hitting currently than corona pandemic. But that's the price what we are paying. Now I'm going to be talking about another aspect of heart failure management with low ejection fraction. And I limit my discussion to how the device play a role. There are major challenges. We have been listening in the last 2-3 hours, but we did not specifically address this challenge posed by the heart failure, and that is the cardiac arrhythmias. How do they further deteriorate the heart failure situation, and they also sometimes predispose to sudden cardiac death. Well, in addition to all those medications, guideline directed, as well as the lifestyle modifications, device therapy certainly to an extent help meet these significant challenges. When we talk about the device therapy, I think the timing is crucial. There will be a phase where I believe that phase gives us the golden window to execute that therapy. That's an opportunity. It could be very early on. There are people whom you could be certain that they may not do well with GDMT very early on with minimal symptoms. Certainly when they are not doing well with the GDMT, maybe. And then there are phases where device therapies don't just work. So timing is crucial to get the optimal benefit from the device implantation. We have been discussing over and over again in the last few hours about the guideline-directed medical therapy. The medications have been put into the guidelines because they specifically act at certain targets, which will help in pump failure improvement. And there are certain drugs which would specifically bring down the arrhythmia burden and also this vicious event of sudden cardiac arrest due to the malignant ventricular arrhythmias. But not all the time they are successful in preventing an event, and definitely the drugs will not come into action when it is emergently required. So the drugs do have their large benefit because they act on specific targets. They prevent the occurrence of the arrhythmia. They help in reducing the sudden cardiac arrest events. But when the arrhythmia takes place, or when there is this sudden cardiac arrest because of the ongoing ventricular tachyarrhythmias, the patient needs to have a device implanted to overcome that acute crisis. Drug therapy has undergone significant evolution, and we have been discussing about this ARNI and SGLT2 inhibitors and the various ranges of reduction in the ejection fraction. They have been shown to not only improve the symptoms, they increase the survival, and also many a times we have seen in the literature the newer drugs have also brought down the sudden cardiac arrest with or without the patient is already having the device. So there are better outcomes because of the modern era of the medications of RNA and SGLT2 inhibitors. So the guidelines have evolved with respect to the GDMT, but the guidelines with respect to the recommendation for the device therapy have not evolved. Over the last 1 decade, the guidelines do not really have made any significant changes with respect to the indication of devices in heart failure. I think it is time to revise the guidelines for the appropriate positioning of device therapy in the management of congestive heart failure. With the advent of newer drugs, there is seeming to be necessity for more synergy between drugs and devices. I'm going to be talking with respect to the device therapy in CHF with respect to 2 specific devices: a device which would prevent the sudden cardiac arrest, which is implantable cardioverter defibrillator. Another one in specific situations with reduced ejection fraction, with the dyssynchrony among the pumping chambers, which is indirectly understood by the widening of the QRS, more specifically left bundle branch block, which imparts dyssynchrony between the pumping segments. And that device is the cardiac resynchronization therapy, which is popularly called CRT. And then there are devices, the combination of both of them. I would be discussing some newer devices, which are like leadless or subcutaneous devices for pacing therapy or preventing sudden cardiac arrest. I'm also not going to be talking about the devices in the horizon, cardiac contractile modulation or improving the parasympathetic stimulation. When it comes to the ICD efficacy, well, it has been already established and there are no questions which are asked when ICD is being indicated when the patient has already had a resuscitated arrest, what is called secondary prevention of sudden cardiac death. As long back as in the late 1900s, the efficacy of ICD was being shown, and the major trials like AVID, CASH, and SITS have looked into several thousand patients who have had a resuscitated cardiac arrest, and when they were randomized to the antiarrhythmic drugs, including the beta blockers versus defibrillator, it was shown that the ICDs really prevent sudden cardiac arrest if the patient has already had an ICD with or without underlying heart failure. When it comes to the prevention, where the patient did not have a documented cardiac arrest, there are situations where ICDs could be considered to prevent the sudden cardiac arrest, which are called primary prevention. Several subgroups have been studied in large numbers. For example, in those patients with post-MI left ventricular ejection fraction, which is lower, for example, 35% are low. They did not have any sudden cardiac arrest, but there were markers of an impending event in the form of either in the clinic you finding an SVT, or on a Holter monitoring you are finding an SVT. And then if you also have done some EP study, there was an inducible VT. ICDs were considered to be superior to an antiarrhythmic or a conventional therapy in MADIT trial. Similarly, in post-MI patients who are not considered to be improving with respect to the ejection fraction, for example, you have monitored them for more than a month after the PCI or more than 3 months after a CABG. If the ejection fraction continues to be lower, they were thought to have the chance of developing sudden cardiac arrest, and ICD prevented significantly the sudden cardiac arrest events in MADIT-2 trial. A larger trial, which included heterogeneous population of heart failure patients who have been observed for more than 3 months in heart failure and continue to be improving symptomatic wise. For example, they were minimally symptomatic, but more than 3 months into heart failure with ejection fraction less than 35%, whether ischemic cardiomyopathy or a non-ischemic cardiomyopathy of any etiology, it was shown that the ICDs as compared to the conventional therapy helped in preventing specifically sudden cardiac arrest. And they tend to have in general, reduced cause of death for any reasons. A Danish in subgroup of non-ischemic cardiomyopathy was shown that they may be benefited as well. Guideline-directed medical therapy, as I said, it reduces the risk of arrhythmias, it reduces the risk of sudden cardiac arrest. It also reduces probably the symptoms related with heart failure. But when it comes to an acute event like an arrhythmia or a sudden cardiac arrest, it is now very clear that they may not be able to replace the ICDs. So there are certain patients we need to be looking at very carefully. For example, a 19-year-old male who had been doing so well, in fact, he plays regularly the cricket game. He presents here with a near syncope. Now, you do the echocardiogram. If he has an ejection fraction 35%, well, you may start looking at various causes of syncope, but ejection fraction 35%, a history of syncope, most likely he would have had a symptom of either a monomorphic VT or a polymorphic VT or a VF, most likely, unless it is documented otherwise. We should believe ejection fraction 35%, a history of a syncope, irrespective of the age and no prior history. I think we should be considering that that could be most likely because of a malignant ventricular arrhythmia, and what the patient might be benefited is with an ICD. ICDs alone can protect from such catastrophic events. GDMT may reduce the appropriate shocks, but one should remember ICDs will save lives because they act as an emergency physician when there is a malignant event. Cardiac resynchronization therapy so CHF with respect to large ventricles with widened QRS, CRT is considered to be helpful. ECS recommends in those patients with heart failure, large hearts, sinus rhythm, and the QRS if it is wide, and especially when it is left bundle branch block, ejection fraction less than 35%, CRT needs to be recommended. In special situations where the patient continues to have symptoms related to CHF, and it's also either a paroxysmal or a persistent AF, and there are episodes of uncontrolled heart rate responsible for hospitalization, AV junction ablation and CRT may help. Similarly, patients who have symptoms of CHF with relatively preserved ejection fraction, but they have a requirement for the pacemaker, CRT is indicated. So I thought I discussed the two specific devices, the ICDs and CRTs, and thank you for the opportunity.